And I'm going to start off with the first powerhouse of obstetric anesthesia and the first of our two female leaders in our specialty of obstetric anesthesia, Dr. Sheila Cohen. She graduated from medical school in my hometown of Manchester in northwest England, and she came to Stanford University in 1973. And 2 years later, Sheila became the division chief. And at that time, there was actually no fellows, and there was only 2 faculty members as well. So very different times. And Sheila, basically, she was instrumental in sowing the seeds and laying the foundations to create the division that we know today, where we have 17 faculty members and 4 fellows, and we're now the most academically productive division in the world as well. So a lot of that is thanks to Sheila. So can I just ask for a round of applause for Sheila? Sheila's currently an active emeritus professor, but she has a very, very impressive CV. She's a former SOAP president, the Society for Obstetric, Anesthesia and Perinatology, and she served also on the Californian Maternal Mortality Review Committee as well. A lot of the research that she did was instrumental in basically serving what we do today, particularly the work that she did surrounding the use of neuraxial opioids for labor analgesia and surgical anesthesia in OB. She also did some great work on walking epidurals as well and the treatment of spinal hypotension. Now, moving on to the second powerhouse of obstetric anesthesia, Dr. Michaela Farber. So she is currently the chief of the OB division at the Brigham and Women's Hospital in Boston. She is an associate professor at Harvard Medical School, and she serves on the Massachusetts Maternal Mortality Review Committee and is a current board of director for the Society of Obstetric, Anesthesia and Perinatology. She's mentored a very impressive 56 fellows as a fellowship program director previously, prior to her becoming the chief. And she has a lot of interests which are very relevant to maternal mortality, particularly surrounding the management of postpartum hemorrhage, peripartum coagulation, point of care coagulation testing, and pharmacokinetics of tranexamic acid. So, Michaela, it's lovely to have the opportunity to introduce you, and thank you for coming.
Well, thank you so much, Pervez, for that incredible and kind introduction. It's truly an honor for me to be here today to present the Dr. Sheila Cohen annual lecture on what's new in obstetric anesthesia. And there are several reasons that make this particularly meaningful that I'm going to just articulate before we get started. This lecture is named after Dr. Gerard Ostheimer, who was a pioneer in obstetric and regional anesthesia. He built his career and spent his career at Brigham and Women's Hospital in Boston, which is where I'm coming from today. I didn't have the opportunity to know Jerry directly, but Dr. Cohen did. And she attested to the fact that he was certainly very passionate about his field and had the power to connect with people through the passion he had in these specialties. So in honor of both of them today, my hope is that I can connect with you all and share my passion by presenting the most recent and relevant literature in obstetric anesthesia. And really, again, it's an honor that this is called the Sheila Cohen Annual Lecture. Dr. Cohen, her work in our specialty formed the foundation for me as I began my career in obstetric anesthesiology. And if you look at these people, so many of them, I could spend the entire hour talking about my connections with the obstetric anesthesia division at this institution, former fellows, former colleagues, collaborators in research, and most importantly, incredible friends that I've developed in the course of my career. So this happens to be my last Ostheimer lecture I'm delivering, and I can't think of a more special place to give it than at Stanford. I do have several disclosures. I have recent grant funding from PRICO for technology-based research in postpartum hemorrhage, and I serve on 2 advisory boards for hemorrhage-related devices and products. So the preparation for the Ostheimer lecture is a daunting process. I've outlined it briefly here on the left. Ultimately, we're asked to review a calendar's worth of literature in our specialty and distill it into a 1-hour lecture. For me, that meant selecting 89 journals and reviewing nearly 1,400 manuscripts over the course of a year. Pervez could attest to the grueling nature of this. He's doing it right now on behalf of SOAP for the May annual meeting. Papers are graded and selected for their novelty, scientific integrity, clinical importance, and research implications. Ultimately, distilled, again, like I said, into a syllabus, mine contains 165 papers. When I started this process, what struck me is the expanse of literature out there in our specialty. It reminded me of this forest, vast, enormous, full of growth, beautiful but intimidating, and really easy to get lost in. And I don't want to do that today. Instead of getting lost, my hope is that I can take you on a pathway through the woods towards excellence in peri-delivery care. And just a bit on formatting. First of all, for your reference, if you'd like, this is a QR code that has my actual syllabus. I'm happy to email it to you as well. And for formatting logistics, you can see in the top right corner, the number pertains to the syllabus itself. The title of the paper and authors will appear at the top center of the screen, and the journal name in the bottom left. And most of my slides are in the form of a question with a clinically relevant take-home point. And, you know, I've given this lecture quite a bit. It's 2023, this is the 2021 literature. So I've sprinkled in a few updates on particular topics that I think there have been interesting and relevant updates for you to know. And those are going to be in blue border instead of green. So it was 2015 when Dr. Guglielminotti and colleagues reported diminishing anesthesia complications in obstetrics, but increasing peri-delivery morbidity in a New York State data analysis. And an accompanying editorial, Drs. Bateman and Meyer advocated for peri-delivery care in obstetric anesthesia. We can and should do so much more than spinals and epidurals. To engage with the multidisciplinary team, implement maternal safety bundles, not just staff, but define maternal levels of care. Think about what creates and what a center of excellence should look like for maternal care. And ultimately, through these efforts, stem obstetric morbidity. This is the theme of my talk. And through that lens, we're going to start with hot topics of 2021, which were autism spectrum disorder and inequities in maternal outcomes. We'll move through the peripartum period, and we'll finish up to focus on some key drivers of maternal morbidity. So to start, autism spectrum disorder and labor epidural analgesia. In 2020, Q and colleagues reported a 37% increased rate of autism spectrum disorder in offspring of mothers who used labor epidural analgesia. And this sparked public and scientific concern. For the public, am I putting my future child at risk simply by choosing to have labor epidural pain relief? And for the scientific, is there ascertainment bias, selection bias, residual confounding? Is there misclassification? Is there a biologically plausible association here? These questions drove many important papers, 3 of which are shown here and 1 of which I'll go into detail on a bit. Weiler and colleagues reported a longitudinal cohort of vaginal deliveries. These were singleton live infants born in Manitoba, Canada from 05 to 16, and this was a population-based data set. The exposure was maternal epidural analgesia in labor, and their primary outcome was autism diagnosis in the offspring at 18 months or older. Now, the important point of this paper is they carefully controlled for potential confounders, and they did that through inverse probability of treatment-weighted Cox proportional hazards regression analysis. They did this in the whole population as well as in a sibling cohort. So here's what they found. Just over 123,000 offspring were in this data set. The exposure rate to labor epidural analgesia was 38.2%. Those who had epidurals were more likely to be nulliparous, have premature rupture of membranes, antepartum hemorrhage, be induced for labor, and have fetal distress. The cumulative risk of autism in this group was 2.1% in those with epidural exposure, compared to just 1.7% in those who did not have epidurals. However, after adjusting for maternal and perinatal covariates, you can see in models 3, 4, and 5 that association with autism diminished with a hazard ratio from 1.15 to 1.08 down to 0.97 in the within sibling analysis. So diminishing association. And I can say that this study really was the bedrock of good data to suggest against an association with autism spectrum disorder and labor epidurals. And multiple papers have since come out, which I'll get to in a moment. But we can take this data and assure patients that they don't have to worry about this and avoid getting epidural labor pain relief, putting themselves at risk for severe pain that's unnecessary, and also at risk for general anesthesia in the context of an emergency cesarean delivery without an epidural. This is a really impactful editorial on the topic at this QR code by Drs. Wong and Stevens. And at the time, this controversy was really alive and well. SOAP hosted a really nice town hall that Brian Bateman was very involved in, and SOAP created really nice patient education tools like the one you can see here. And this is one of my blue update slides. Like I said, many, many more studies have proliferated on this topic, and I think honestly it's time that we can put it to rest. These two I selected here are large registry studies, one from Denmark and one from Canada. The first at the top, both, by the way, were accompanied with editorials. And the first showed no association, similar to the paper I just presented. And the second showed a small association. But the key here is there continues to be a lack of biological plausibility for the association. And for that reason, both the authors and the editorialists of the second paper suggest that that association is likely due to confounders that we have yet to identify. So when we think about maternal inequities, maternal mortality is our highest concern. And I really think that as obstetric anesthesiologists, we're perfectly trained, skilled, and poised to have absolute impact in driving down maternal morbidity and mortality. But we have to understand the actual problems. And the United Kingdom at this point still does the very best job in delineating that. And this is their report, the Embrace UK report of 2021. This was a report of maternal deaths from pregnancy through 6 weeks postpartum in the United Kingdom in a triennium, and that was from 2017 to 2019. The maternal mortality ratio in this triennium was 8.8 per 100,000. And there was a statistically non-significant reduction in mortality from the preceding triennium, which suggests that continued work is essential. In fact, they looked and found that in 37% of deaths, maternal deaths, different care may have resulted in different outcomes, better outcomes rather. So what were the causes of death? Well, indirect causes of death were led by cardiac disease, followed by seizure and stroke. And direct causes of maternal death were venous thromboembolism, followed by sepsis, hemorrhage, and suicide. And if you look on the right, it's easy to appreciate that Black and Asian women over the course of a decade here fared much worse than white women in the United Kingdom in terms of maternal mortality. And the important thing here is that this is despite the fact that the National Health Service in the United Kingdom provides safe, free, quality care to all. And it suggests that these disparities are driven by non-medical causes. So in response to this concern, the Royal College of Obstetricians and Gynecologists created this tool, urging providers to listen without assumptions, remove barriers to communication, check and provide good information and documentation, and ultimately serve as champions against racial disparity. So let's shift our gears to look at the United States. What I've done here is I've put some Centers for Disease Control data from 3 years, from 2018 through 2020. You can look at the maternal mortality ratio from these years in the bottom row. Deaths per 100,000 live births went from 17.4 in 2018 up to 23.8 in 2020. So we're certainly not moving in the right direction in our country, but the news gets even worse. If you happen to be Black in America, the maternal mortality ratio in 2020 was 55.3 per 100,000 compared to 19.1. So these are glaring racial disparities that really require our highest priority to understand and tackle and eradicate. Furthermore, misclassification has, our data collection has been fraught with misclassification in our country. And this is thought to be due to coding changes and protracted implementation of a pregnancy checkbox on our death certificates. And really what that means is through misclassification, understanding temporal trends in our country is a little bit complicated. And I honestly think we can't fix the problem until we understand it better. And we can be part of the solution for that through getting engaged at the hospital level and at the state level in the mortality review committees. The Centers for Disease Control has implemented a better way to collect data so that we can compare it across the board with a system called Maria. It's been implemented in 31 states thus far, and I urge everyone to get involved and evaluate this because we have wonderful perspective to offer on our mortality review committees as critical care specialists. So what to do? Well, we don't need to reinvent the wheel. We should use systems that have worked. What I've done here is put an overlay of the United Kingdom on the United States. It's easy to appreciate that it's about 1/40th the size of our country. So what's been an incredible success in the United Kingdom, the Embrace UK, can and should be replicated at the state level in the United States. And it's very exciting to be here in California and talk about how well California has done in this way with its California Maternal Quality Care Collaborative. This is an overlay of California over the UK, by the way. But through really conscientious and direct surveillance over the last decade, you can see on the graph on the right side that California has managed to drive down its maternal mortality in comparison to the rest of the country and really serves as a true model for what we should be doing nationally to fix this problem. In fact, in 2021, the CMQCC released its first maternal mortality report, and this actually covered a 9-year period from 08 to 16. And what I've done here is I've highlighted causes of death or death that occurred in pregnancy through 6 days postpartum as the most likely time we'll be involved giving peri-delivery care as obstetric anesthesiologists. And you can appreciate at these time periods, the driving causes of death are hemorrhage and cardiac illness, followed by sepsis and hypertensive disorders and then thrombosis. So these are the things we really should be honing in on and addressing as well as we can across centers. And if you cast your glance across the top, it's also easy to appreciate that at all time points, cardiac illness predominates as a driving cause of maternal death. With that in mind, it's essential that we focus on cardio obstetrics, be a key player in the cardio obstetrics team, particularly at centers like this, at tertiary and quaternary centers where these highest risk cardiac patients are going to deliver. This is a QR for a really high impact expert review on the topic by Doctors Meng and Arndt, essentially outlining how we can and how we should be focusing our expertise in this area. And just an update relevant to this topic is, as a board of director, a SOAP board of directors member, I'm working with SOAP President Klaus Kujera right now on an initiative to identify a SOAP representative for every single state in our country. Because again, I really think the way to tackle this is at the state level. Our first year is to establish those SOAP representatives at the state level, and we're asking that they identify and connect with the section chiefs at every hospital that has at least 1,000 deliveries per year within their state, and also to check with their Department of Public Health Mortality Review Committee to make sure that there's an obstetric anesthesiologist at the table. In fact, 8 have joined MMRC since we started this initiative across different states. And I'm very pleased to say that the lead state representative here is your own Dr. Brendan Carvalho. He's got his work cut out for him. There are 172 hospitals in California that meet this criterion of more than 1,000 deliveries per year. So thank you, Brendan, in advance for that. And ultimately, what we're hoping to establish is a powerful network to disseminate best practices and tangible ways that we can drive down morbidity and mortality at the state level. So I'm moving on to the peripartum period and specifically labor and delivery. And what I want to discuss related to this is thrombocytopenia guidelines, some strategies for best dosing of labor epidurals, and what we should be thinking about when we're topping up for cesarean delivery, especially for urgent cesarean deliveries. How low will you go is what every person asks every obstetric anesthesiologist at every scientific meeting as it relates to platelet count for safe neuraxial techniques to avoid the complication of neuraxial hematoma. In the context of limited published data, this resource that came out in 2021 was a welcome resource from SOAP. It's our consensus statement on neuraxial procedures in patients with thrombocytopenia. SOAP formed a task force and performed a modified Delphi process for consensus gathering among experts and did a systematic review to create an evidence-based document on the topic. And its algorithm is partially shown here, and I want to point your attention to the left. As historically has been the case, the guideline does verify that for isolated thrombocytopenia and counts of 70,000 or greater, it's likely that neuraxial techniques are safe. And on the right, you can see that it also delineates that for counts between 50 and 70,000 in the context of isolated thrombocytopenia, there is a worthwhile discussion of risk benefits, so that a little liberalization of how low we can go. If you have chosen to do an epidural for a patient, there are a lot of options on the labor epidural analgesia menu these days. For starters, you can have a straight epidural, you can have a combined spinal epidural, you can have a dural puncture epidural, and then your choice of maintenance is continuous epidural infusion or programmed intermittent epidural bolus. And the sides always make a lot of difference, especially when you're interpreting the literature. What have they used a patient-controlled epidural analgesia button? What is the test dose being used? What's the loading dose? What concentration of medications being used? And at what dosing interval? These are questions we should be thinking about every day as we're optimizing our pain relief. And there are a lot of questions, and there's reflectively a lot of literature coming through at all times to help us answer these questions better. I'm going to highlight one that's related to the onset of labor epidural pain relief. Dural puncture epidural initiation has been associated with faster onset of pain relief and better sacral spread, while the programmed intermittent epidural bolus, or PIEB, maintenance has also been associated with better analgesia and lower local anesthetic consumption. So in this study, Song and colleagues asked the question, what if we combine these two initiation and maintenance strategies compared to straight epidural or dural puncture initiation and continuous epidural infusion? Of note, you can see in the gray box, they did not look at epidural initiation and PIB maintenance. They randomized patients to one of three groups, and after their epidural or dural puncture initiation, all patients got a test dose of 1.5% lidocaine with epinephrine and a 10 milliliter loading dose of the medication shown in the box, ropivacaine and sufentanil. Continuous epidural groups then got 8 mils per hour of that mix, and the PIEB group got that mix 8 mils on the hour every hour. And their primary outcome was time to adequate analgesia. So here's what they found. You can look at the Kaplan-Meier curve on the left and appreciate that the DPE-PIB combination, shown in red, had the fastest time of pain relief onset, with a median of 6 minutes and a hazard ratio of 1.8 compared to the epidural continuous group, which is shown in black. And if you look on the right, you can also appreciate that that combination of DPE-PIB, again shown in red, had the lowest local anesthetic consumption. And that was due to fewer required patient and provider boluses through the course of labor. So this appears to be a promising combination, the DPE-PIB, in terms of offering faster onset of analgesia, a medication-sparing effect, and no untoward side effects. There are a couple of caveats to this study. Because the epidural initiation was not evaluated, you can't completely untangle the benefits of the DPE from the PIEB. And if you use something for maintenance other than ropivacaine and sufentanil, I use bupivacaine and fentanyl, for example, you might have different results. And the literature that's come out since this study and even before this study is a little bit inconsistent in terms of the benefits of the dural puncture epidural. So we need further work, we need higher quality work. And I think it's very important that we standardize what we're using for test dose maintenance and try to understand differences through equal comparisons. But there have been a plethora of publications in the since this study that I'm presenting on the DPE, and I think it reflects people's interest in it. This was a retrospective analysis asking whether the replacement rate is different between dural puncture epidural and straight epidurals. It was a retrospective small study of 3477 epidurals, and they found a lower failure rate in the DPE group compared to epidurals, straight epidurals with a 3.3% risk reduction. And importantly, there was no increased signal of headache or blood patch requirement in the DPE group, which is something that many people are also wondering about. The best dosing interval for DPE has also been studied in the recent past. In other words, if you use a DPE as opposed to a straight initiation, are all the studies we've done on PIEB for dosing intervals still going to hold true? These authors did a randomized double-blind study looking at the intervals listed here and found the effective interval in 90% was essentially the same as it is in our DPE, non-DPE PIEB studies. So here you are on the labor floor, you've placed an epidural in your patient, you're running back to the operating room for an emergency cesarean delivery. You might ask, is 3% chloroprocaine as good as 2% lidocaine with epinephrine, bicarbonate, and fentanyl? Answering such a question under such harrowing circumstances is unreasonable. So Sharawi and colleagues created a model, and they did a randomized triple-blind non-inferiority study. And I like this study. It's unique for its non-inferiority study design, and also for the creation of a model to look at something that we otherwise would have a lot of difficulty doing. So here's their model. They randomized patients scheduled for elective cesarean delivery. 1 hour prior to surgery, they placed a combined spinal epidural. They dosed it with intrathecal morphine and bupivacaine and fentanyl, and to a T10 level followed by continuous infusion. And then at the time of surgery, patients received one of these two study meds, first as a 3 milliliter test dose and then as a 17 milliliter bolus over 2 minutes. Their primary outcome was time to T7 loss to touch sensation. 70 patients were randomized over the course of 2 years, and their primary outcome time to T7 block was 6:55 seconds in the chloroprocaine versus 5:58 in the lidocaine group, with a mean difference of 97 seconds. However, if you look on the right, you can appreciate the 90% confidence interval crossed zero, and the non-inferiority margin of 3 minutes was exceeded, and that was a predefined non-inferiority margin. So in this case, they could not demonstrate non-inferiority of the chloroprocaine to lidocaine, though they did suggest that either of these medications are very effective for rapid extension of your epidural to avoid general anesthesia during cesarean delivery that's urgent from the labor floor. So you might be asking, why choose a non-inferiority study to begin with? And you'll recognize an author on this paper. You can speak to him personally here, Dr. Sultan. But this is a really nice editorial that discusses the utility of a non-inferiority study design. Essentially, if you have drug A, it's similar to drug B, and you think it would be very difficult to demonstrate a difference, but you want to see whether one is no worse than the other. It's a good study design, and I think it really has added relevance in this era of drug shortages, where we're needing to ask questions about replacing things as they have diminished supply. So moving on to cesarean delivery, and I'm going to focus on, there are many, many other topics in the syllabus that I came up with, but I'm going to focus on left uterine displacement, whether we should be using prophylactic secondary uterotonics to prevent postpartum hemorrhage, and a cesarean delivery app that can help you connect better with your patients in the peri-delivery period. So every year or so, a paper comes out to get us talking again about left uterine displacement to avoid aortocable compression in the context of women having cesarean delivery under spinal anesthesia. And it's a relevant conversation to have for this procedure, this surgery that is the most common surgery out there, for which we cause hypotension with our spinals in almost every case. If you look here, this is looking head on at a patient. You've tilted them with a wedge under their right hip. The Cardiff wedge was nearly 30 degrees, and it was originally created to promote venous return during maternal cardiac arrest. But it's also advocated in this circumstance to prevent cable compression under spinal anesthesia. Unfortunately, the angle itself is rarely achieved. 30 is quite steep. It's poorly tolerated by most surgeons and even anesthesiologists and patients. And Dr. Lee and colleagues have recently shown that if you keep a patient perfectly flat after an epidural, after spinal for cesarean delivery, and maintain maternal blood pressure with phenylephrine infusion, you can achieve favorable newborn outcomes, albeit with a higher phenylephrine requirement. So this current study by Liu and colleagues re-explores this question, looking at two different tilt angles compared to the supine position, and the intervention difference in maternal position was only done during surgical prep and drape, with all patients then placed flat for surgery. They randomized 25 patients per group, and their primary outcome was a newborn outcome, umbilical arterial pH. They also looked at maternal blood pressure, vasopressor requirement, and incidence of hypotension. So here's what they found. The supine is shown in blue, and it's easy to appreciate in the graph that there was a bigger dip in maternal blood pressure in the first 15 minutes after a spinal in the supine group compared to the 15 and 30-degree tilt. With active control of maternal hemodynamics, maternal blood pressure, as with previous studies, there was no compromise in fetal acid base status in the supine group, but to achieve that blood pressure control, not surprisingly, there was a higher phenylephrine requirement. So the take home here is that the 30-degree tilt position during surgical prep and drape lowered vasopressor requirement. And this might not be all that surprising. You might be wondering why I have this paper in this talk. Should we aim to limit phenylephrine exposure, or can we just put this to rest and keep patients flat and just adjust our phenylephrine accordingly? Well, a couple papers came out in the 2021 calendar year that got me thinking, we're not always monitoring end organ effects of these medications that we give every single day. But these papers gave me pause. This was non-obstetric, and these were brain tumor patients having MRI to demonstrate worse cerebral microcirculation with high-dose phenylephrine infusion. And then there was a translational study in mice and humans to demonstrate a profound immunomodulatory effect of high-dose phenylephrine. So again, we're not thinking about end organ and systemic effects of medications, but I think the best answer is avoiding when you can. And we have a simple, easy mechanical maneuver, the left uterine displacement tilt, that can lower exposure to vasopressors. And this paper tells us that it's a reasonable compromise to do so, at least during surgical prep and drape. So here you are on the labor floor in the middle of the night doing your third add-on C-section for failure to progress. You're worried about uterine atony in such patients who have been on oxytocin for many, many hours in labor and they have chorioamnionitis. Balke and colleagues asked, in such patients, would prophylactic administration of a secondary uterotonic along with your oxytocin be effective in preventing postpartum hemorrhage? She randomized patients to one of three groups shown, with oxytocin alone, oxytocin with ergonovine or carboprost, and checked tone at standardized times, with their primary outcome intraoperative need for additional uterotonics. They captured 100 patients over 6 years in this study and found there was absolutely no difference in need for additional uterotonics between the groups, nor was there difference in estimated blood loss, nausea, vomiting, tone, estimated blood loss, or hypotension. They did see an increased rate of nausea and vomiting in the combined group. So their take home was that for patients in this high-risk group for postpartum hemorrhage from uterine atony, there's no benefit to prophylactic ergonovine or carboprost. But I have an important update here that's conflicting in the message it sends. This was a randomized trial in a very similar patient population, those who were having failure to progress cesarean delivery, who had been on oxytocin for induction. And what this paper showed in a randomized fashion was that placebo compared to methyl-organovine, the methergin administration yielded benefit with lower additional uterotonic requirement, better tone, less hemorrhage, and lower transfusion. So why the differences in these studies? Well, this was addressed by the authors themselves because it was unexpected. And I think the important points to make here are that the dosing strategies were very different. Methyl-organovine was given intramuscularly in this US study. In the preceding study in Canada, it was given intravenously. And oxytocin was not bolused in this study as it was in the other study. And I think this is worth our attention because this is more consistent with US practices for both medications administered. So if we could connect better with patients and engage with them in the peri-delivery, and this could be perioperative period, not just for cesarean deliveries, we may enhance patient satisfaction. We may become better at extracting, better at following up for complications, and we may even increase our margin of safety and drive down the disparities I've mentioned. The C-Care app was created specifically to provide education and follow-up for patients having cesarean delivery. And this study looked at its use and patient engagement using the app. After orientation to the app, almost all patients, 29 of 30, returned to the app after their cesarean delivery, most frequently in the first week after surgery, for a median of 15 times over 30 days. And they most frequently looked at pain control, education, and what to expect after surgery. 83% would have recommended it to someone else. So it was a popular app. And importantly, if you look on the right, really granular information about recovery and side effects were obtained. So I think this is the future of our peri-delivery expansion of care, harnessing technology to do a better job following up patients in a way that provides more information and better safety. So I'm going to move on to the postpartum period, and I'm only going to talk about fascial plane blocks for the sake of time. Who should be receiving TAP or QL blocks after cesarean delivery, and do any patients in particular benefit more? We know from the past literature that transversus abdominis plane or TAP blocks have minimal benefit to non-chronic pain across the board patients having cesarean delivery when intrathecal morphine is administered. And it turns out in this first study, it's similar findings with the quadratus lumborum or QL block after cesarean under spinal anesthesia. A systematic review of 12 trials and more than 900 patients demonstrated that QL blocks, similar to TAPs, were of minimal benefit if there was intrathecal morphine on board. A second study looked at liposomal bupivacaine TAPs in the same patient population and found that liposomal bupivacaine TAPs were non-inferior to intrathecal morphine alone. So this could suggest that these blocks will be good for patients who, for whatever reason, haven't received or can't receive intrathecal morphine. And a third study compared QL blocks to TAP blocks. There's very limited data comparing these two blocks. So Dr. Sultan and colleagues looked at a systematic review and did a network meta-analysis. They captured 31 trials and more than 2,000 patients. And the combinations of comparisons shown, QL versus control, QL versus TAP, and TAP versus control, the primary outcome was cumulative 24-hour morphine equivalent consumption. And 2 network models were required for this analysis. Patients and studies where intrathecal morphine was excluded on the left, and studies in which intrathecal morphine was included on the right. And you can see that in the absence of morphine, both the QL and TAP blocks appeared to be superior to control, but they appeared to not have any, one was not better than the other in comparison to each other. But these benefits diminished in the presence of intrathecal morphine. So the take home really is that QL and TAP blocks appear to be equivalent for post-cesarean delivery pain, but neither add benefit if an intrathecal morphine is used. The caveat is that further studies are warranted to look at different block approaches and different dosing modalities. So the jury is still out, and I think certainly looking at higher risk patient populations, such as those with opioid use disorder. A follow-up trial that I thought was interesting, again, co-authored by Dr. Sultan, was looking at what different approach, so just expanding beyond TAP and QL approaches, and looking at efficacy depending on approach to these fascial plane blocks. A network meta-analysis again was performed of randomized controlled trials. They identified 114 trials, and you can really appreciate the spectrum of different approaches shown on the right. And I've reported, their report was reduction in morphine equivalents, which I've reported here compared to the placebo. And you can see the superiority was highest in ilioinguinal, iliohypogastric blocks, and in exclusion of trials that used intrathecal morphine, shown in orange, it was even more pronounced. There was a lot of heterogeneity in this study, so the jury remains out as to the very best block approach, but I think this is an important step in understanding this better. So I'm ending here with talking about key drivers of maternal morbidity. For the sake of time, I'm skipping over hypertension. I'm going to touch upon headache and hemorrhage. Post-oral puncture headache is the most serious common complication of obstetric anesthesia. If you think of the numbers, approximately 2.8 million patients in the United States will have labor epidural analgesia. 1% will have a complication of a wet tap, and 60 to 80% of those will evolve to a post-oral puncture headache. And that's 22,000 women or so in the United States alone who suffer this complication as a direct result of their obstetric anesthesia care. The International Headache Society defines post-oral puncture headache as a self-limited process, but since the early 90s, there have been concerns raised that this indeed has chronic sequelae, and chronic headache specifically has come into more focus in the recent years. In 2021, multiple studies came out looking at chronic headache after spinal headache from post-oral puncture headache from a wet tap at the time of delivery. And these three studies, you may recognize Dr. Ansari and colleagues in the last row, looked at longer follow-up periods from 6 to 50 months postpartum. And they found that chronic headache had a much higher incidence in those who had a post-oral puncture headache at the time of delivery, shown in orange, compared to those who had uneventful labor epidurals. So again, showing chronic headache incidence increased at a longer-term follow-up postpartum. Backache was also reported in 2 of these studies. And a 4th study by Niraj and colleagues was prospective observational out of the United Kingdom. They captured 89 patients who had an accidental dural puncture or wet tap and matched them to 167 patients who had uneventful labor epidurals, had patients perform questionnaires immediately postpartum and then at 6, 12, and 18 months, with the primary outcome persistent headache at 18 months. And this was well adjusted for chronic headache, back pain, and depression. So 79% of patients in their cohort of wet taps developed the post-oral puncture headache. And by the way, 53% of their cohort did receive blood patch for treatment. But if you look at their primary outcome of headache at 18 months, you can see that those who had the accidental dural puncture at the time of delivery had a 58.4% rate of chronic headache reported at 18 months, compared to just 17.4% in the patients with uneventful epidurals. So there seems to definitely be a signal here, and that's despite controlling for headache and anxiety and depression history. The authors went further to look at whether there were anything done at the time of post-oral puncture headache to mitigate this chronic headache problem. And they found that the use of spinal catheters at the time of a wet tap didn't seem to have any impact on the incidence of chronic headache. The provision of epidural blood patches was associated with less severity and less chronicity of headache. And MRIs were done in a subgroup of patients with the chronic headache symptoms at 18 months, and they failed to demonstrate intracranial hypotension as a cause of the headache. So like any really good study, there are more questions left than answers. The authors proposed a mechanism of intracranial nociceptor activation with trigeminal neuron sensitization. We really need to dig into this further and understand why epidural blood patch seem to lower the incidence of chronic headache but doesn't eradicate it. What are we doing in the acute phase for these headaches that is contributing to or helping to mitigate chronic headache? We need to do a better job following patients up to understand and try to prevent this serious complication in otherwise healthy young women. I think the weight of the data to at this time suggests that at the very least we should include the risk of chronic headache in our informed consent process for labor epidurals. And like I said, we need to really dig in on trying to figure out best strategies to address and prevent them whenever possible. Just an update, this remains an interest in the literature. This was a systematic review and meta-analysis that captured 12 studies and more than 6,000 wet taps and over 1 million uncomplicated epidurals. And the studies are of varying quality, but ultimately suggest signals for headache, backache, neck pain, and depression in association with post-oral puncture headache. So this is a huge area of research and interest for obstetric anesthesiologists. So I'm ending on hemorrhage, and I'm only going to focus on tranexamic acid and situational awareness in the last 5 or 10 minutes here. Since the World Maternal Antifibrinolytic Trial, or WOMAN trial of 2017 came out, randomizing 20,000 women to get either a gram of TXA or placebo at the onset of postpartum hemorrhage, and demonstrated as a secondary analysis a reduction in death from hemorrhage. TXA has become a mainstay as an option for postpartum hemorrhage management. And there's been a lot of interest in whether we should be giving tranexamic acid prophylactically. So the TRAP trial, or TRAP1, was an original trial looking at TXA prophylaxis in patients having vaginal delivery that demonstrated no difference in outcome, so no utility of prophylactically administering the medication for patients having vaginal delivery. The TRAP2 trial by the same author group came out in 2021, and it looked at cesarean delivery patients in a multi-center double-blind randomized design across 27 maternity hospitals in France. Patients received prophylactic TXA, a gram versus placebo within 3 minutes of their delivery. And they had an interesting primary outcome of calculated estimated blood loss more than 1 liter or transfusion within 48 hours. 4,439 patients were randomized over 2 years, and what they found was their calculated estimated blood loss in the tranexamic acid group was lower, 26.7% versus 31.6% in the control group with an adjusted risk ratio of 0.84. The authors were very careful to point out, however, that clinically relevant hemorrhage outcomes were completely unchanged between the groups, whether they had tranexamic acid or not. So if you look here at these clinically relevant hemorrhage-related outcomes shown in orange, there was absolutely no difference, despite a slight signal potentially of a calculated estimated blood loss difference. And I want to draw your attention to the mean between group difference between blood loss, whether calculated or quantitated. It was 30 or 97 mils. And I think we could all argue, or I think we could all agree that that's of limited clinical significance. And when you have a limited effect of a medication, I think it's worthwhile to look a little bit more closely at the potential risk. The risk of thrombosis in the TRAP2 was 4.01, with a very, very wide confidence interval to suggest that we need much more better powered studies if we want to answer a question of thrombosis risk. At the time, though, I think this prophylactic data, this highest quality prophylactic data we have from the TRAP and TRAP2 trials convinced me that we shouldn't be giving tranexamic acid prophylactically after either mode of delivery. We should certainly not prioritize it over any other treatment for postpartum hemorrhage. And an important point and message to convey across, anyone providing care in obstetric anesthesia is we really must be champions of safety for this medication. There have been increasing reports of accidental spinal injection of tranexamic acid. If you think of drug shortages, you have different formulations of medications coming out all the time. They look different, vials, bags, even ampules. This is an ampule of TXA next to an ampule of bupivacaine. There have been more than 30 reports of accidental spinal injection for women having a cesarean delivery, and the mortality rate in obstetrics for this accident is 86%. So be a champion of safety. If you're grabbing a vial of bupivacaine to add to your CSE, our spinal kits have the bupivacaine, which is a safety mechanism in itself, but we really must be absolutely vigilant so that this never happens to any patient. So just a couple important, interesting points on TXA that the literature is focused on these days is what exactly is happening when we give this dose of medication to pregnant women having postpartum hemorrhage. We want the antifibrinolytic effect, and that's 10 to 20 mics per mil, shown in gold at the top here. And if you look at if you look at the toxicity for TXA, the serum levels are ranging much higher from the literature we can understand. For thrombosis, it's 150 mics per mil. And for seizure risk that you see more in cardiac surgery, it's up to 300 mics per mil because of the higher dosing strategies used in cardiac. So a couple interesting papers came out, many interesting papers. Here are two of them. Again, to look at what serum level we're actually achieving when we give a gram, it's a very low dose, to a hemorrhaging patient who happens to be pregnant. And is that dose actually achieving antifibrinolysis that we think it is? This was a pharmacokinetic study from my center. We gave TXA a gram to patients having cesarean delivery at risk, high risk for hemorrhage, and demonstrated that within minutes of dosing, within minutes of dosing, 60 mics per mil serum level was achieved as a peak TXA serum level. And we're happy to say that through the course of an hour after treatment, even in the context of hemorrhage, we stayed above that 10 mic per mil threshold for antifibrinolysis. And the TRACES trial was a separate study on TXA, looking at antifibrinolytic effect using D-dimers as a surrogate for it. And cesarean delivery patients who had postpartum hemorrhage and D-dimer levels checked were reported. They demonstrated more fibrinolysis in the placebo group and a dose dependent response with a half dose of TXA versus a gram with lower D-dimer levels to indicate that we are indeed impacting fibrinolysis at this dose. So the finale here is that for postpartum hemorrhage, too little is done too late. This is a common mantra. And the key here is that postpartum hemorrhage is the leading cause of preventable morbidity. And despite our understanding of it, this preventable morbidity continues to plague even centers with high resources. So this group does a lot of really high quality work looking at qualitative issues and what are the human factors behind our failure to treat postpartum hemorrhage. We all understand and agree that visual estimation of blood loss is notoriously inaccurate. But this group is also asking the question, what about quantitation of blood loss? In our decision-making processes for postpartum hemorrhage, is it the amount and number of quantitative blood loss that makes a difference, or is it the speed and nature of bleeding? They did a mixed methods analysis with qualitative and simulation work, interviewing 28 groups or people. On the left, they demonstrated that QBL does help to detect hemorrhage in some cases. It helps focus the team on bleeding, but it's impractical and time-consuming. One person reported, I just know it when I see it. I have a gut instinct, I have experience, and I can use nonverbal cues for my management. And the simulation component of the study, looking at management of fast versus slow bleeding, the authors found that all participants responded faster to fast blood loss. Most of the time it was below a threshold of 500 mils, and only less than half requested QBL anyway. So they conclude that QBL can be abandoned unless clinical cues are concerning, at which point then you can start measuring blood loss. I'll have to respectfully disagree with that, because if gut instinct were all we needed, then preventable morbidity from hemorrhage in tertiary centers would be a non-issue. And it continues to be a problem. I think women deserve more than just gut instinct. And if you look at these triggers for hemorrhage management, QBL, patient's vital signs, the actual situational awareness, the feedback patients are giving you, their risk factors at the time they check in for delivery, we need to think about how we can refine all of these triggers for hemorrhage management, how they can synergize with each other. They're never going to be enough in isolation, but collectively, together, the weight of collective concern should drive our management and help us refine how we treat women and minimize preventable morbidity. It's a tough task, but it's a task worth doing. I hope I've convinced you in this hour that obstetric anesthesiologists are providing excellent peri-delivery care. We all should think about joining our hospital level and state mortality review committees to this effort. Define how maternal levels of care should look in our hospitals and how we can push the bar for higher excellence, be better at refining, be better at how we predict and treat pain and headache specifically, extend care and long-term morbidity tracking as it relates to post-dural puncture headache, and be leaders in how we lead our response teams to lower morbidity from hypertension and hemorrhage. If I've piqued your interest, we do have an annual meeting. This year it's in New Orleans. I would be thrilled to see you there. And I really, again, can't thank you enough for having me here today for this Sheila Cohen annual lecture. I want to thank Dr. Cohen and Brian Bateman, Jill Abier, Brendan Carvalho, and the entire OB Anesthesia faculty. And I really hope I can connect with as many of you as possible today. Thank you.
That opportunities. We have the room. So
That's okay. I'll get back behind. What Cesar is asking about is the OBCMI, and this is a validated tool that Dr. Bateman established from coding data and how it relates to maternal morbidity and mortality, morbidity outcomes. And what the tool involves is maternal demographic risk and obstetric risk and comorbidity risk. And it's been very helpful for us to implement in our unit because it can be scored at the time of admission and it reflects a composite risk for a patient. We're really just exploring what that means in terms of clinical integration. Dr. Sarah Ray Easter worked with Brian, I think in 2018 or 19, to publish on the clinical utility and the clinical use of this tool in predicting severe maternal morbidity outcomes. And it was found that if the score itself was higher than 6, the risk for severe maternal morbidity increased quite a bit. So we use the tool at our center to capture global risk of patients. We discuss the score at our twice daily rounds and why the patients have a higher score when they have it. And I think, to your point, Cesar, we're finding information as we go with doing research on it for more tangible ways we can think about our planning, our delivery planning. So if a patient has a higher OB comorbidity index score and we found that their risk for general anesthesia increases, we'll be prompted to think more about their airway if they have a higher OBCMI. And the same seems to be the case for acquired heart disease decompensation. We're looking at that right now. And postpartum hemorrhage, which is unpublished data. I don't know if Brian has any comments on it. But I find it very helpful because it's not just looking for, if you're looking at cardiac disease and pregnancy and risk assessment, and you want to use the Zahara or the CARPREG score, that focuses on the cardiac illness itself, and that's important. But the OBCMI score incorporates their obstetric risk factors in conjunction with their heart disease risk. So it's a little bit more all-encompassing in that sense.
I was curious about the instance backache in patients that didn't have a dural instance of in pregnant patients.
The signal for backache was reported in some, but not all of these chronic headache studies. And I think your point is well taken. Backache is, insidious and it's ubiquitous. But with these studies with chronic headache and chronic backache post, a delivery process that involved an epidural, there's always a signal in the controls of a higher rate or a rate, an incidence. And so the data I presented with 58% or so of headache risk versus 17%, 17% of the controls also had chronic headache. And it was a similar distribution. So there is certainly a background of chronic backache because we all get backache. But it seems to be much more, much higher in association after the spinal headache itself. And when I first read the data, I thought, well, certainly this must correlate with the provision of a blood patch because blood patches cause such profound backache, but it didn't seem to align with that completely. So it's, it's very interesting data, and I think it's fraught with reporting bias. If you ask someone about a headache over and over again, they might start reporting that they have a headache. So, I think it's important. And the reason I presented the fourth study in detail was they tried to account for that and capture and eliminate bias as much as possible, but it's very difficult. Nonetheless, we have a signal for chronic headache after spinal headache, and it's something that deserves more attention. When patients recover from a spinal headache, we consider it a victory when we call them and they're weaning off of their Fiorset and they feel better, and we never talk to them again. So I think these papers are really interesting and helpful to remind us that we should extend our peri-delivery care longer for a complication we're responsible for.
I had a question about maternal mortality review committees, because you
Yeah.
serve on one. Is there kind of a blueprint for how one should be set up or run, very similar between?
Well, this is $1 million question, Pervez. And I think my experience on the Mass Maternal Mortality Review Committee, which I have Brian to thank for, actually, he got me involved in this, and I'm just so passionate about it now, is that it's very organized within our Department of Public Health, and the Maria reporting system is helping standardize across review committees across states. But I've spoken to several people. It turns out there are quite a few obstetric anesthesiologists on these committees already, which is heartening. But the discussions are interesting. So to answer your question, it's different in every state. And I think that's the first step we need to address. There may be points, it may be reflective of different issues from state to state that have created different systems. But I think until we standardize our processes, we're not going to be able to compare and contrast between states. So that's one of the overarching goals we have with the SOAP initiative, is to get people on the same page. And the Centers for Disease Control is doing this. Let me not take credit for that. They're implementing the Maria tool and funding its implementation in most states by now, so that we can collect data in a more standardized way and compare it across states. So there's progress, but it's all over the board right now.
Or a comment than, and I don't remember what I'm gonna. We did a study here. Where we focused on the effect of attention. We found that the patients who tested upset more motor talk and the ability. And I think when we're looking at some of these studies where we did receive it, 5% lidocaine with that. Can't ignore that test. Decrease the likelihood of finding a difference. Makes it a long way to help.
Yeah, it's an excellent point. And I think that reviewing the literature in preparation for this lecture and understanding the context to put it in made me really realize how heterogeneous the literature is in this area. And it's the nature of the game, but I think when you're comparing apples to oranges for studies where different local anesthetics are used, different concentrations, it's kind of, I think it's compounded, or it's made it very difficult to understand best practice over time. I think there's so many different combinations of dosing strategies that are used. It's hard to compare one study to the other. And I think your point's well taken. We're probably muting a potential effect we might see with a strong test dose. Thanks, everyone. Thank you.